Thank you, Bill. Good afternoon, everyone. So if you notice some overlap, if you were in the earlier sessions this morning with my talk this morning around 8:20 in the morning, maybe you were not quite awake back then. This is your chance to hear it again to a certain extent, but we're really focusing on the drugs that have to do with ulcerative colitis more than Crohn's here. Here are some disclosures also in the book. And we're going to start with much more basic stuff and just talk about pharmacokinetics and note that drug levels really do seem to matter. And if we're talking about mechanisms, we also have to talk about types of drugs. You know, we can talk about small molecule agents, of which there are more and more in development for IBD, which is a good thing, I think, and also biologics. And I think until recently, we really didn't appreciate that for biologics, drug levels do matter, that trough levels on average have some meaning. But interestingly, for biologic therapies, often giving too much of the drug doesn't seem to be much of a problem. It's more having too little of the drug. Now, that's a little bit different with small molecules, where if you overdose, you'll tend to get more off-target toxicities. So this is a little bit of discrepancy between these two types of agents. And also, if we think about drug metabolism, you know, in the classic sense of a drug, a small molecule, a compound, generally the drug will be broken down, metabolized, distributed after it's taken up either by injection or taken orally. But then it'll be broken down by oxidation, cytochrome P450 and other cytochromes, conjugation through glucuronidation, and then the metabolites are either conjugated into a stable adduct and then excreted by the kidney or broken down and excreted in the liver, some of it making its way out of the GI tract. And this, of course, this pathway will vary very much from agent to agent. Quite differently, if we're talking about antibody-based therapies, there is some element of renal filtration, catabolism. There's catabolism within the tissue, breakdown, and there is also neonatal FC receptor. So uptake in the reticuloendothelial system is really the most important factor, other than just sort of adsorption of the antibody onto the antigen to create an antigen-antibody complex, and then catabolism of the complex. So these mechanisms are quite different depending on the drug that we're talking about. And then finally, as I mentioned earlier this morning, we're seeing a number of new agents that are actually antisense oligonucleotides. So these are basically going to bind, they're small nucleotides that are going to bind to messenger RNA species very specifically, targeting one adduct, and then prevent translation into protein, and thereby blocking that protein essentially. So it's a way of inhibiting the formation of one protein. But as I also mentioned earlier, these don't get absorbed very well, so they have more of a topical effect. There are some drugs that have been used in ophthalmic utilization, and you could think that in the bowel, topical administration, either delivery orally through a protective mechanism or enema, might be beneficial. So all these things are in play. And we'll start talking about mechanisms and acknowledge that nearly 20 years into the era of TNF blockers, we're still discussing how these drugs work and also how they're metabolized. And the pharmacodynamics are even more relevant when we're thinking about biosimilars potentially, as was also touched on. In rheumatoid arthritis, infliximab is thought to work predominantly through neutralizing soluble and transmembrane tumor necrosis factor. But in IBD, we have additional signals for efficacy, and this has to do with membrane association with the TNF and the Fc gamma receptor, and this triggers apoptosis in some of these cells or antibody-dependent cell-mediated toxicity, cytotoxicity. These mechanisms may be more important than simply binding to the TNF in circulation. So as an example of that, etanercept is thought to be effective in RA and probably not effective in IBD, at least insofar it's been studied, and this may have to do with these different mechanisms. So when we're thinking about the biosimilars, it has been shown at least in one study, and you can see that this is a battlefield right now between the innovator drugs and the biosimilar manufacturers. But at least once it's been shown that CTP13, which is an infliximab biosimilar, shows reduced binding in vitro to the Fc gamma receptor 3A, and as well as to NK cells isolated from healthy donors and also Crohn's patients. And whether this actually makes a difference in terms of the realistic efficacy of these agents is not known, but you do see differences in an ADCC assay, so cell-mediated cytotoxicity. So I think we're going to have to keep an eye on this as it goes forward. The data are not conclusive one way or the other. So moving forward to another mechanism, the next type of agent that came along are the agents that block adhesion. And this is a complex process. What happens is basically there's rolling and then activation of the leukocyte along the endothelium as they connect to more and more integrins and adhesion molecules, and then there's firm adhesion, and then finally you get diapedesis of the cell into the inflamed mucosa. So the whole idea is that if you can interfere with this process in some way, then you're going to prevent inflammatory cells from making it from the circulation into the bowel. In Crohn's disease or ulcerative colitis, this should work, and clearly it does. Now, as we know, there are a number of different potential approaches here, and the prototypical approach was with natalizumab. That was the first one out of the gate, and it's an alpha-4 blocker, so it blocks alpha-4 beta-1 as well as alpha-4 beta-7. To remind you, alpha-4 beta-7 has as its ligand MAdCAM, mucosal addressing cellular adhesion molecule 1, which is predominantly found in the gut endothelium, but also to a small extent in the upper respiratory endothelium and also to a lesser extent in the urogenital epithelium. So this accounts for the selectivity of vedolizumab, which interferes with the interaction of alpha-4 beta-7 with MAdCAM by binding to alpha-4 beta-7 integrin on the leukocyte. But there are other ways of doing this. Etrolizumab is an antibody against beta-7. Therefore, it's going to block alpha-4 beta-7 and its interaction with MAdCAM, as well as alpha-E beta-7 and its interaction with E-cadherin, which is what homes intraepithelial lymphocytes into the gut. It's not known yet whether that really makes a difference. But the bottom line is all the things that I've mentioned other than natalizumab should be fairly gut selective. They won't block immune surveillance to the brain, and therefore we don't expect any PML from any of these. And as you can see in a very nice experiment on the bottom, when you immunize patients with hepatitis B vaccine peripherally and you simultaneously immunize them with cholera vaccine and you treat them with vedolizumab, you inhibit the mucosal immune responses to cholera vaccine, but you have perfectly good immune responses to peripheral vaccination to hepatitis B. So this underscores the gut-specific immune suppression, if you will, of vedolizumab, and we would expect with others like it that are gut selective. And additionally, we have to keep saying that even though there is a black box warning for PML with vedolizumab, there still have not been any cases, and we would have expected to see a few dozen by now, given the broad use. So there are many other ways of doing this. I mentioned a bunch of them. The ones that I won't go further into are Versanon, which is a CCR9 inhibitor. This was explored in Crohn's disease, and this is a molecule that also homes lymphocytes into primarily the small bowel. This was studied in phase 2 and 3 and actually failed to show efficacy, and so that doesn't move forward. But another agent that you see in the middle is alkaforsin, which is an antisense molecule that is an ICAM1 antisense, so that will block adhesion theoretically anywhere where there's inflammation in the body. It should be noted that alkaforsin was ISIS 2302 in a prior life. That was studied as an intravenous preparation in patients with Crohn's disease, if I'm recalling correctly, and didn't prove to be efficacious. However, it is being reborn potentially, at least in clinical trials, as a topical delivery as a potential treatment for pouchitis. So relevant to topical effects of antisense oligonucleotides, this may be a more rational use of this particular agent. Now, I'll show you some of the data on etrolizumab here, and we're looking at clinical remission at week 10, and you can see the clear superiority of the drug, particularly in anti-TNF naive patients. It still also seems to be efficacious in all comers, but if you look at the anti-TNF experienced patients, it's actually very hard to detect an effect. And so this is a theme that seems to come through with many of the anti-integrin molecules, not just etrolizumab. They seem to be more efficacious in patients who are anti-TNF naive, but we also know that that's true even for patients going on to their second TNF inhibitor. So really for any agent, for ustekinumab, the one after you fail anti-TNF is always less efficacious. And for mucosal healing, you actually see slightly more robust effects of this agent. And I think this shows you a little bit the discrepancy between mucosal healing, which is very objective, and symptomatic response, indicating that a lot of patients who do heal the mucosa still have kind of remnant clinical symptoms, usually of diarrhea, not so much of rectal bleeding. Now, I also showed these data earlier this morning, and I'm really always intrigued by these data because, at least with this agent, anti-MAdCAM, so here not the integrin, but the ligand for alpha-4 beta-7 within the gut endothelium, this shows a bell-shaped curve, and why you see attenuation of the response at the highest doses is not clear. We should remember that the lymphocytes and activated leukocytes that are homing toward the gut are not homogeneous. They have different functions. Some of them are effector cells, the troublemaker cells, and some of them are regulatory cells. So one wonders if differentially there may be more expression of alpha-4 beta-7 on those cells that are regulatory cells, and if you go too far and block too much the interaction, actually you're keeping more of the regulatory cells from getting into the mucosa. But at this point, all of this is really speculation. We'll turn to another really quite different means of controlling leukocyte trafficking, and these are the sphingosine 1-phosphate receptor agonists. And these S1P regulates many biological functions, including cell proliferation, angiogenesis, many things, but also immune cell trafficking. And most importantly for inflammatory bowel disease, it has to do with the egress of lymphocyte populations and other kinds of cells, NK cells, out of the lymph node and into the circulation. The first in class was fingolimod, and this is a pan-S1P receptor agonist. And this was approved for the treatment of multiple sclerosis. The adverse event of note is bradycardia in the first 24 hours, and then there's tachyphylaxis to this effect, and it doesn't seem to be problematic. So the dose in this case is ramped up to help prevent this from occurring and may require some monitoring. But the drug is fairly effective in multiple sclerosis and a real breakthrough. But there are several second-generation S1P1 receptor agonists with more selectivity and different pharmacokinetics and safety profile, and these are under development for IBD. So again, the way this works is S1P1 receptor agonism induces internalization of the receptor on the surface of the lymphocytes, and therefore it functionally antagonizes it, and therefore you have the loss of ability to respond to the gradient of S1P within the lymph node endothelium. So the lymphocytes just become trapped in the lymph nodes. They're not dead, they're not apoptosing, they're just sitting there, they're alive, and they're not in circulation. And then when you withdraw the drug, very shortly, the receptor is expressed again, and these lymphocytes again re-enter into circulation. So you see this first effect as a depression of lymphocyte counts. Absolute lymphocyte counts are reduced with two of the doses studied with Ozanimod, RPC 1063, as it was previously called, that were studied in an ulcerative colitis study. And here are the clinical results. So you can see that clinical remission at week 8 was superior to placebo, and you can see clinical response at week 8 likewise was superior to placebo. So this is a pretty innocuous medication, and if you look at longer-term outcomes, I'll tell you the safety in a moment, long-term outcomes of clinical remission are something like a quarter of the patients compared to only 6% on placebo, clinical response, nearly half the patients, and mucosal healing in about a third out to 32 weeks. There are other agents out there being studied of this sort, but what is unique about Ozanimod seems to be its predilection, especially to bind to S1P1, rather selectively, as you can see in this diagram. The others may not be quite as selective. So in terms of the bradycardia, very little was seen of that of any clinical note in the clinical trials. Other things that are monitored for liver function abnormalities, and those were by and large not seen, certainly not anything that meets Hy's law. And there were some ocular things in animal models, but that hasn't been seen either. So it seems to be safe. I should note no cases of PML have been described to my knowledge, and I think we'll see where this goes, but it's a promising oral agent for ulcerative colitis. Then we get to this agent, Apremilast, which is a phosphodiesterase 4 inhibitor. At this point, it's just under study. There's a strong preclinical rationale for PDE4 inhibition in ameliorating immune responses. You can see all the complex things that happen downstream. Upstream of this is cyclic AMP activation, so it's basically tamping down that pathway, and in theory should be effective in ulcerative colitis as well. Some of the side effects that do occur may be nausea, upper respiratory tract infection, nasopharyngitis, some diarrhea, which if it's a real issue could be a problem for our UC patients, headache, but no increase in opportunistic infections, even though this is an immune modulating type of mechanism. Now we're coming to the JAK inhibitors, or so-called JAK inhibs, and remember, as I told you this morning, the Janus kinases, or JAKs, sit at the base within the cell of the cytokine receptors and help in intracellular signaling through phosphorylation and docking of STAT molecules, which then make their way into the nucleus, and then downstream of that are a bunch of pro-inflammatory cytokines. And which cytokines trigger which JAKs, you can see here. It's sort of a mix and match scenario. But some of these may be beneficial in UC treatment, and others may be harmful in UC treatment. We wouldn't want to induce erythropoietin-like blockade, because then we might see more anemia. But it may be beneficial to block IL-23, for example, or IL-2, or interferon gamma, or IL-12. So the two that have been used in IBD, of the two, only tofacitinib so far has been used in ulcerative colitis. I think David will show you the data. But tofacitinib is said to be more selectively inhibiting JAK1 and 3 over JAK2. And filgotinib is said to be more JAK1 over JAK2 and JAK3. So they may have slightly distinct profiles with modulation of pro-inflammatory cytokines. The actual and hypothetical risks, there are cancers that have been seen if you look at the label, but actually you don't see any increased risk of these things over placebo. There's theoretical concern for gastrointestinal perforation, but again, not really seen. A real thing is total cholesterol rising, but no apparent increase in cardiovascular risk, because perhaps HDL rises in proportion to LDL. There are some patients who have CK elevation, but this does not seem to be terribly problematic. Occasionally you see LFT abnormalities. Rarely do you see lymphocytopenia, neutropenia, and low hemoglobin. Infections are reported, but actually they don't occur with any frequency. The one that I mentioned this morning and remind you of are herpetic infections, which seem to occur more frequently with tofacitinib than we would see with infliximab or adalimumab or golimumab, any of the anti-TNF antibodies. Now, I think this may be potentially a problem that is not a big problem, assuming there is adoption of this new vaccine that was reported in the New England Journal earlier this fall, which seems to be 95% effective potentially, or 90% effective in preventing herpes zoster and postherpetic neuralgia. So finally, I'll just mention this and not show you really any of the data, but to remind you that the anti-P40 antibody will block both IL-12 and IL-23, both very important immunologic cytokines. Remind you too that the JAK kinases are downstream of these in certain combinations, JAK2 and TYK2 for IL-12 and JAK2 and TYK2 for IL-23, and that these are important pathways, both blocking IL-23 alone and combination of IL-12 and 23. And probably will work in ulcerative colitis as in Crohn's, even though there are no data yet in ulcerative colitis. So to conclude, the agents directed at leukocyte trafficking continue to be developed in new and different ways. These seem to be very safe, particularly the gut-selective therapies, and we're looking at both biologics and small molecules in development. But there's much more to be learned about the pharmacodynamic differences and how these approaches, how these agents may differ and how they'll affect our approach, and whether there are any differential efficacy in Crohn's and UC, as there are suggestions in what we have so far. The small molecules are making their way, tofacitinib and other JAK inhibitors, Ozanimod and other S1P1 receptor agonists, and Apremilast and other PDE4 inhibitors. And then finally, I think we will see studies of anti-P40 and anti-P19. Theoretically, these should also be effective in UC. So that's the rundown of what is kind of in the near future for novel therapies for ulcerative colitis specifically. And thanks for your attention.